Hello, and welcome to my presentation about diabetic ketoacidosis, or DKA, by Brittany Oldfield. Meet the patient. LW is a 20-year-old Caucasian male presenting to the emergency department unconscious with coffee grounds emesis, a Glasgow Coma Scale or GCS of 3, labored breathing, tachypnea, and the girlfriend states the patient had been urinating a lot. I was a student nurse in the ICU where LW was admitted for suspected diabetic ketoacidosis awaiting lab results. Prior to admission, the patient had not been diagnosed with diabetes at all. Lab results were resulted as the following. Blood glucose was 1500, urine was positive for ketones, white blood cells was 54,000 per microliter, anion gap was 24, BUN was elevated as well as the creatinine. The patient was found unresponsive over a trash can with coffee grounds emesis inside. In the EMS documented that his pupils were fixed and dilated and was intubated in the ED. When he arrived to the ED, he was intubated and was only started on fluids. The nurse contacted the doctor and asked for the diabetic ketoacidosis protocol to follow, so he can start following that and get the patient back to a stable level. By the time the patient was admitted to the ICU, it had been 2 hours since he was brought into the emergency department. The first thing we did was an assessment. We made sure that his heart and lungs were sounding properly, and then I examined his eyes. In the ED report, it stated that his eyes were fixed and dilated. When I did my assessment, his eyes were responsive to light and were about a size 3. Some symptoms of diabetic ketoacidosis. It includes an elevated blood glucose, ketones in the urine, elevated white blood count, elevated anion gap, BUN is elevated, creatinine is elevated, and increased urine output, as well as fruity smelling breath, increased thirst, and nausea and vomiting. My patient had multiple of these symptoms. He had the elevated glucose of 1500, his ketones were positive in his urine, he had an elevated white blood count of 54,000 per microliter, his anion gap was 24, and his BUN and creatinine were both elevated. And prior to being brought into the ED, his girlfriend said that he did have an increased urine output, and they described it as he was peeing about every 15 to 20 minutes. Even though he was not drinking as much, he still had the increased urine output. Since he was intubated by the time we got him, we could not smell the fruity breath, and he was also intubated, so he was NPO, so we could not see if he had an increased thirst. But when he came in, he was vomiting a lot, and the girlfriend did state that he had a decreased appetite and was feeling pretty nauseous prior to admission. So these are the signs and symptoms of diabetic ketoacidosis. While a patient does not need to have every single one of these symptoms, they can have most of them or only some of them. But the main ones that they need to have is the elevated blood glucose, ketones in the urine must be positive, the anion gap must be above 10, and a very common sign is the fruity smelling breath. On the next slide, I will talk about the individuals at risk for diabetic ketoacidosis and how they are related to my patient. These are the individuals that are at risk for diabetic ketoacidosis, or DKA. Type 1 diabetics are more at risk than type 2 diabetics, but type 2 diabetics can still develop DKA. Type 2 diabetics also have more severe symptoms and have higher mortality rates. Another group of individuals that are more at risk are people who are currently sick, people who live in urban communities because their access to insulin may not be as great, substance abuse, low socioeconomic status, and children's ages 10 to 20. A study showed that children ages 10 to 20 had the most chances of developing DKA, and then it plateaued about at the age from 20 to about 40, and then after 40 it increased because the patients who were elderly do not handle their insulin as well. My patient suffered from substance abuse, specifically opioids, and he and his girlfriend had been clean for about 2 weeks prior to admission to the ICU. Since he was intubated, we had to use certain type of medications to keep him pain-free as well as sedated, and was not trying to pull out the ETT tube. The family requested that we tried our best not to use fentanyl or any other type of opioids to sedate him and keep him pain-free, as they did not want him to go back into his opioid addiction. Me and the nurse that was assigned to him tried our best to avoid having to be putting him on a fentanyl drip to prevent him from relapsing in his drug addiction. On the next slide, I'll be talking about the plan of care and the treatment that we used for the day that we took care of this patient. This was the plan and care and treatment of our patient for the day that he was admitted to the ICU. The main things that we wanted to do were monitor his blood glucose, manage his blood glucose by administering IV insulin, then subcutaneous insulin once his blood glucose was below 250. While we did not get below 250 in one day, which is a good sign, we did get down from 1500 down to about 700, which was a very good and gradual decrease. We were expected to follow the diabetic ketoacidosis protocol, which was ordered by the doctors, which included replenishing the electrolytes and monitoring his potassium, phosphorus, and magnesium. We were also monitoring and maintaining his vital signs, one, since he was intubated, but also since he came in with increased respirations, as well as his heart rate was also very fast. The other thing we really needed to do was replace fluids to prevent dehydration. Lactated ringers were started when he came up, and once that was finished, we started him on normal saline. After that, we continued normal saline and a bolus to make sure that he would not become dehydrated. This is the algorithm that we are following for the DKA protocol in a condensed form. On the far left, we have fluids, and we gave him LR until that ran out. We then started him on normal saline until his blood glucose was 250 with the insulin drip going. Once his blood glucose would reach 250, which we did not get in one day, we would start him on 5% dextrose and normal saline to prevent hypoglycemia and bottoming him out. During this time, we monitored his blood glucose about every hour to 2 hours. In the middle, we have the insulin. This was his insulin drip that we were monitoring. If his glucose dropped by greater than 175, then we decreased the rate by half. We did not want his blood glucose dropping too fast, or we could put him in hypoglycemia. If his glucose dropped by less than 125, then we doubled the rate, so it would decrease faster than that because that's too slow of a rate. Our main goal was to titrate the insulin to maintain 125 to 175. On the far right, we had one of his electrolytes that we were replacing. While we looked and replaced magnesium and phosphorus and potassium, our main goal was monitoring his potassium. If the potassium was greater than 5.3, we would hold the potassium and monitor. If his potassium was less than 3.3, we would give him 10 to 30 microequivalents of potassium going along the protocol. We would also recheck his labs to make sure they were within the normal range. While the DKA protocol goes way more into depth, this is a very condensed form to give a good understanding on what we were following for the day. We were titrating the insulin about every hour, as well as constantly monitoring all of his electrolytes and his blood glucose every hour to make sure that they were decreasing at a normal rate or staying within normal range for his electrolytes or increasing. Here are my references that I used throughout my presentation, which you can pause and read and also look up and understand a little bit more where I got my information from. Thank you for listening to my presentation about my patient that I had with diabetic ketoacidosis. Thank you.